This is Rory Spiegel and Ryan Radecki, and this is the Annals of Emergency Medicine podcast. It is August 2025. Ryan, how you doing?
I'm doing fantastic down here. How's life in the United States?
It's life in the United States. We've now been taken over by the National Guard, so things are getting dire.
Well, you've never been safer.
All right, why don't we get into the articles? I think you're up first.
Yep. The first article we'll talk about from this issue is called Effectiveness of Point-of-Care High-Sensitivity Troponin Testing in the Emergency Department, a randomized controlled trial. Lead author here is Viola Thulin, and they're at Haukeland University Hospital in Norway. And this is a bit of a funny trial, and the most remarkable thing about it, in my view, is that these authors, despite being universally on the payroll for the diagnostics companies, put out a study that's actually pretty blasé about point-of-care troponin. The concept here is pretty simple and straightforward. When you order a troponin and test them for chest pain, what do you think is better? A result that comes back in 30 minutes or a result that comes back in an hour? Which one do you think will help you get your patient out of the emergency department faster? Well, the answer should obviously be the faster troponin test, right? But these authors went out to prove it and basically failed. They used a central laboratory high-sensitivity troponin from Roche and a point-of-care high-sensitivity troponin from Siemens, each with their own sort of time 0 and 1 hour accelerated diagnostic pathway for either a single troponin or a 2 troponin rule-out. Then they randomized 1,600 patients presenting with chest pain and a suspected acute coronary syndrome to one of the 2 testing pathways. Results came back, as I mentioned before, about half an hour faster for the point-of-care troponin. But the difference in median ED length of stay between arms was a mere 6 minutes. And there was no difference in the percent of patients discharged within 3 hours or within 6 hours. But there are a ton of weird issues here. First of all, well, randomization sounds good. Randomizing on a per-patient basis is problematic. Working in the emergency department, you get used to a certain workflow and cadence for results. If I know my patients are going to have troponin results in half an hour, I'll go looking for them at the half an hour mark to get my disposition. If it's going to take an hour, I'll go look at an hour. I think they've burned themselves by mixing the workflow timings for these 2 cohorts to the detriment of the point-of-care workflow. There were also issues, probably related, to whether ED clinicians trusted the point-of-care assay. Patients who received the point-of-care assay also had their samples run at the same time in the central lab, and ED clinicians could request those sample results as well. And they did so in about a quarter of the results, and that would obviously eliminate any timing advantage from the point-of-care assay. Then, well, the big ugly reason why this failed, they only achieved a definitive rule-in or rule-out for 50% of that point-of-care cohort, as opposed to over 70% of their lab troponin cohort. If you have to wait for further consultation or specialty review prior to discharge in the ones who fall in that intermediate zone, then you've lost the advantage of having a quicker assay. I find it a bit perplexing they wouldn't have done some observational work beforehand to tune in their rule-out criteria to be a better match for their lab criteria, but it may also simply reflect the lack of precision in these point-of-care assays. Lastly, these results are probably entirely confounded by inefficient processes surrounding these patients at this emergency department. Despite 64% of patients being ruled out by the laboratory accelerated diagnostic pathway, they only discharged 40% from the ED. A large percentage of each cohort underwent an echocardiogram in the ED, and nearly a third of each cohort was admitted to undergo CT coronary angiography. Most of these patients had their repeat troponin test, where applicable, around 2 hours, but only 15% even had an ED length of stay of less than 3 hours. It's pretty easy to read between the lines here and see how these results are very unlikely to generalize to your hospital, culture, and implementation. I think the real key here is, regardless, is the failure to reach a final rule-in or rule-out determination for half the patients in the point-of-care arm. Since all point-of-care systems and pathways are not created equal, this may or may not apply to your vendor and department.
Yeah, I think that last point's key is the fact that the point of care or the troponin in general is often not the rate limiting step in most emergency departments, at least around the United States, right? Like the inefficiencies in our systems, often all the lab tests are back. The patient's been waiting in the waiting room or where they wait after their tests are drawn for hours prior to seeing a clinician. And so I never understood this, like trying to decrease the length of time it takes to get a troponin back. It's just this goal that seems unachievable and unlikely to help. Like, I get when we were admitting every single chest pain to the hospital, a protocol that reduces the amount of patients admitted to the hospital, fantastic. Maybe reducing it earlier than 6 hours to 3 hours also seems like a meaningful goal. But after that, you start getting into these differences that are so small and unlikely to change due to all the other rate limiting steps that come with being in an emergency department in modern America.
The other thing I think about is that this is kind of a zero-sum game. It's like, okay, I have 10 patients here, and the troponin result comes back earlier. So I go and talk to that patient, and I talk about their troponin result, and I get them a disposition. In the meantime, I've neglected my other 9 patients, and those patients now all have added a minute or two to their length of stay. You know, you can't really detect how much time you've spent with this patient, but you only have a finite number of minutes you can spend with a patient to dispose them. And if somebody's labs come back earlier than another person's, that just means that that other person waits a little bit longer for you to get back around to them. I mean, we have a point of care troponin assay in our emergency department, and I think we're going to publish research that shows that it disposed people faster. And it's true. For the chest pain people, it disposed them faster because we only just point of care troponin tests and a venous blood gas. And that's all it takes. But it means we're spending all of our time focusing on that chest pain patient, and some other patient somewhere else is waiting to be evaluated by a nurse or a doctor.
Right. What's the value of decreasing length of stay in the ED by an hour for a chest pain patient if it's already reasonably low, especially if it's just going to increase the length of stay of other patients? We'll move it on. Our next article is use of hallway beds, radiology studies, and pain on arrival are associated with patient experience. And the lead author is Diane Kuhn. So patient experience scores are all the rage in the emergency department these days. They're used for evaluating clinicians' performance, reimbursement, so on and so forth. But these scores don't necessarily actually reflect the patient care variables and may actually reflect operation realities of the emergency department. So these authors did a cross-sectional study in a large Midwestern health system involving 13 hospitals. Some of them are academic, some of them are community, so on and so forth. And this was from January 2022 to December 2023. They looked at both adult patients and then the parents and guardians of pediatric patients, all who filled out patient experience scores. They excluded patients who were under state protective services or recently surveyed at the same site. Patient surveys were sent out 48 to 72 hours after discharge, and then they linked these patients in their surveys with data from the EHR, including demographics, triage acuity, wait times, hallway bed placement while the patient was there, labs, radiology, so on and so forth. 7.3% of eligible discharge responded to the survey, and that yielded over 58,000 unique visits. They got a bunch of data back, but essentially what they found was there was a number of operational variables that were strongly associated with an either increase or decrease in patient experience. Hallway beds, not surprisingly, strong negative association with patient experience. If the patient had radiology studies, that was associated with a positive experience. Pain on arrival to the ED, the more severe the pain, the greater the decrease in their score. And higher crowding levels obviously equaled less scores. And so you can see here a lot of the things that basically determine what a patient experience score is going to be are out of control of the clinician themselves. They have to do a lot with the operational problems of an emergency department at any time. Now, obviously, this is a survey study. There's lots of potential bias in it. They even admit that the survey was biased. Younger adults, Black patients, Medicaid patients were all underrepresented in the responders compared to the general cohort presented to the emergency department. That being said, I think this is fairly consistent with data we've seen before, that these experience scores are highly dependent on things that are out of the control of the clinician themselves, longer wait times, more crowding in the emergency department. All these things have a large effects on what these scores are going to be.
Well, this score does differ a little bit different than Press-Ganey, where Press-Ganey is definitely sort of an evaluation that seems like it's of you, of the doctor you saw, and how empathic they were and how well they communicated. In theory, these like ED KHAP scores are supposed to be for interfacility comparisons. So, like, yes, they might be. It's measuring some things that are out of the control of the clinicians, but the hospital system itself has fairly decent control over how crowded or busy your emergency department is, and they can moderate that by changing the staffing levels, increasing staffing, changing the way that patients flow into inpatient wards, changing their elective surgery admissions, those sorts of things. And so if you're trying to like compare facilities to each other and the patient experience at a facility, this is a very different goal than a Press-Ganey score specifically. There's still obviously, like you say, there's problems with this. I mean, if the score is baked in by the type of patient arriving, like the patient arriving in pain is going to have a more negative experience regardless, then these are things that are outside the control of either the clinician or the facility, and that totally invalidates the tool. And obviously, again, this is one of those carts that's already left the barn. I think the attempt is valid, but as usual, they've rolled out something that's half baked.
All right, let's move on.
The next article we'll talk about from this issue is a very brief one. This one's called Housing Status and Longitudinal Care Patterns After Injury. Our lead author here is Hannah Decker, and she's at the University of California, San Francisco. And this is a very simple demonstration of a finding that ought not surprise anyone. Everything is harder when you're unhoused. These authors tracked 6,000 patients with Medicaid as their primary insurance, approximately a third of which were identified as unhoused, colloquially known as homeless, and tracked them forwards and backwards in time for 12 months on either side of a trauma admission to San Francisco General, the only level 1 trauma center in the county. Specifically, they used the San Francisco County databases to track emergency department visits, inpatient admissions, mental health visits, and any outpatient visit before and following their injury exposure. Unsurprisingly, all of these visits increased for both housed and unhoused cohorts following their injury, but increased more for those who were unhoused. This was independent of several subgroups of patients, including those with a history of substance abuse or mental health diagnoses, although follow-up utilization increased even more for those. There are obviously limitations in here regarding classification, tracking of follow-up events, and potential confounding. But I think there's likely some face validity in that recovery is hindered by a lack of a safe, stable home. The main implication here is pretty straightforward. In a comprehensive funding environment where these follow-up appointments and subsequent admissions represent real costs, it is very likely less expensive to provide housing and support services rather than eat the cost of additional follow-up appointments and inpatient admissions. And, it's also slightly more humane.
Yeah. Yeah. I mean, this is entirely not surprising results. Obviously, the most vulnerable of our population are most vulnerable to all the problems that come with an admission to the hospital and the downstream effects of that. I think the problem is it's also fractured, right? Like the same people aren't eating the costs. And so the motivations to get someone housing after a hospital stay like this is just, it's hard to generate.
Yeah. I mean, the people who are directly paying for the aspects of care are divorced from the people who would otherwise pay for the housing support services. And they don't see each other's, they don't see the losses on one side that could be mitigated by an investment on the other side. And then you think about actually returning a person to a better functional status than you found them. Monstrous,
I mean, the crazy part is we have to talk about this in like costs, right? Like it's just not let alone it's the right thing to do, right? Like the fact that we've abandoned such large swaths of our society to live like this, and the only potential way that we could get improvement is to justify this by cost benefit, right? And which is somewhat inhumane
cost benefits to other
itself.
people, let alone like the actual human investment in another human being. Wild. Well, our modern world.
All right. Our next article, Intubation Practices in Community Emergency Departments. And the lead author is Jonathan Key. And so most of the data we have on how we manage emergency airways comes from large academic centers. There's actually very little data looking at how airways are managed in the community. And this is essentially where the majority of intubations happen in the United States. So these authors wanted to take a look and see how they were performing, what they were using, so on and so forth. And they conducted a multi-center retrospective chart review of a little over 11,000 intubations performed all the way back to 2015 to 2022 across 15 community emergency departments throughout Southern California. All these EDs were part of a single integrated healthcare system, but each ED had their own equipment, their own operational decisions, so on and so forth. So the investigators pulled data using standardized intubation procedure notes from Epic, their electronic health record, looking at patient demographics, clinical contact, medication used, equipment used, first pass success, outcomes following the intubation, so on and so forth. They found first pass success was around 80.5%, which plus or minus is similar to what previous studies and academics has shown first pass success rate. Overall failure rate, meaning you were unable to get the airway at all, was very low, 0.2%. Again, pretty in line with what we see in previous data. The medications used, etominate by far was the most common induction agent, 91.6%. And then there was small amount of propofol and small amount of ketamine used. As far as paralytics, early in this time period, succinylcholine was the dominant agent, but over the course of the study, rocuronium took over, starting at 34% and ending at 62%. At the start of the study, direct laryngoscopy was the actual primary technique was used, but by the end, it was mostly video laryngoscopy, all the way up to 78%. There was some cricoid pressure used in some studies. And mortality overall, not surprisingly, was fairly high in these patients, 20% at 24 hours, nearly 30% at 7 days, and 45% at a year. And, this is far less a representation of anything that was going on with intubation and far more a representation of how sick patients are who require intubations in the emergency department. So I think this is, in general, this is what's happening in our community centers. I think it has some face validity. You're using intubation notes, so the granularity of this data can't really be taken into account. I think it's probably fairly reliable what medications they use, what technique they use, first pass success, those kind of metrics are going to be far harder to collect with accuracy in a study like this.
Yeah, and it's worth noting these are all Kaiser EDs in Southern California, so it's going to be reflective of that very specific and relatively homogeneous healthcare system and their practices. So it's going to be when there's a shift like this as far as practice goes, it's going to be everybody all at once. So if rocuronium becomes the preferred induction agent or a paralytic agent, or video laryngoscopy has high penetration, it's going to be a massive rapid shift. And these may or may not reflect what's actually happening in the rest of the community emergency departments out there. It'll be interesting to see if first pass success, 80%, to see if that changed as video laryngoscopy rolled out, just out of curiosity, because so many studies say that it's so much better. But that's just a random curiosity that we don't get from these data.
Despite this being Kaiser and one hospital center, I think this is fairly representative.
It's 15 hospitals, 15 Kaisers.
And, so maybe there are some more nuances in your induction drugs. If you kind of look at a more broad group across the whole country. But I imagine your video laryngoscopy again became the dominant tool of choice everywhere at this point, right? I think very rarely are people using direct laryngoscopy as their primary tool.
The other thing I wondered about these is how often had these individuals in this study intubated in the past year, that kind of thing. Because again, we've seen research from community hospitals from these surveys where, some people intubate once a month, some people intubate once a year. How often are the people intubating, out in these community departments at this Kaiser having this success rate? And maybe this is a rich data set that we'll get a lot more out of. It was an epic form that people filled out after they intubated somebody. So you can see that in the appendix. And so maybe there'll be subsequent data dredging publications out of these data.
We shall see.
We will.
I'm sure it'll come across our desk.
And then it'll come across your ears from us. The next article we'll talk about from this issue is called A Prospective Cohort Study to Determine Which Opioid-Naive Emergency Department Patients Are at Risk of Persistent Opioid Use. Our lead author here is Lorena Abril, and they are at Montefiore Einstein in New York. There are a number of folks out there for whom we can exercise some clinical judgment with respect to risk for opioid misuse. It's an imperfect evidence base, to be sure, but enough to influence prudent prescribing in some situations. On the other hand, you have those for whom they've never been prescribed an opioid, the so-called opioid naive, for whom you cannot really predict their likelihood of descending into misuse or abuse because they've never been exposed to the agent before. This study tries to describe and track the features of those so-called opioid naive and tease out potential predictive features of subsequent misuse. These authors, specifically, hypothesized attributes of euphoria or eagerness to use again would be predictive. But then their definition of opioid naive was also a bit not. To be opioid naive, you only needed to have been opioid or tramadol free in the preceding 6 months by self-report and by New York Prescription Database query. The pain, though, could be from any cause, acute or chronic, but sufficient for being discharged from the ED with an oral opioid, most of whom received oxycodone acetaminophen, most of which was related to musculoskeletal pain. They followed about 700 patients, 17 of whom were deemed to have had persistent opioid use by the end, or greater than 6 prescriptions in a 6-month period. Out of the 6 questions they asked at 48 hours and at 2 weeks, all of the 4 questions about how the opioid made them feel or whether they'd want that medication again showed no predictive association with persistent opioid use, which was the basis of their hypothesis. However, they were also asked at that 2-week time point if they were still having moderate or severe pain and the frequency of the pain. And those with moderate or severe pain, and at least sometimes or often, were highly associated with persistent opioid use, with odds ratios between the 6 to 10 range. So, very small numbers of patients overall with ongoing opioid use, so confidence in and the reliability of these observations is low. They only describe primarily a response to oxycodone, and this is an urban ED in New York, potentially limiting generalizability. Then, the implication here is that persistent use is a gateway or a surrogate for opiate misuse, and these data don't describe the extent to which that might be true either. There just really isn't much here you can use, unfortunately, as an emergency physician to inform safer prescribing practices without also leaving a substantial number of patients potentially undertreated for their painful conditions.
Yeah, I mean, this is the problem with all this data looking at this, that they kind of confound opiate use and opiate misuse into one thing. And just because someone fills an opiate prescription a specific amount of times that we've predefined, we decide that that's opiate misuse when they're not really the same thing. I do think, I mean, when you say it out loud, it's incredibly obvious, but the only predictor of someone's continuing opiates if they're still in pain. Shocking. And so, yeah, I think from like, how do we use this to decide who to prescribe opiates to and who do we not? This obviously is not very helpful. I do think it's fairly interesting that persistent pain is going to be the number one driver for persistent opioid use. And so how do we start using that to fashion treatments that aren't always have to do with the medications you give patients? All this pain was musculoskeletal pain, which we know our pain medication is not very effective for. And, you kind of have to wait for the injury to heal. And if it's a chronic use problem, then obviously you're going to be more inclined to use pain medication for a longer period of time if you don't correct the underlying cause. And so other treatments outside of giving someone or prescribing someone opiates might have a far better therapeutic effect.
And then there's always the question of the validity of actually just asking somebody if they get a euphoric effect from their medication or whether they'd like to use it again and whether they're going to reliably answer that and whether it's a good surrogate for actually whether their body's generating a specific pleasurable response to it. I mean, that's just asking somebody, hey, do you want to have this drug again? Or, hey, are you having fun taking this drug? Are they going to answer honestly? And 2, does that actually have a reliable association with a future opiate misuse? It's, there's nothing here you can sadly take away to inform your practice.
Yeah, except for if someone keeps having pain, they're most likely going to keep wanting some medication to treat their pain. And so trying to address those.
As an emergency physician, is there anything you can use from here to decide which of your patients in front of you you can prescribe opiates for in that index encounter? No. You can't predict whether they're going to have pain 2 and 6 weeks from now and put them and flag them for a future follow-up from a pain medicine specialist or
right. But even if you could, what are you going to do about it? Right. Like you're not going to treat their pain, like it's like, it just might be downstream counseling on if this pain continues, medication becomes less and less effective and kind of working in other therapeutic interventions such as physical therapy, so on and so forth, to try to get to the bottom, the underlying cause of your pain might be a better treatment plan.
Oh, for sure. Although they are obviously going somewhere to get repeat prescriptions. And I would say that the point at which you have that conversation about, well, this isn't going to work anymore, and we need to come up with a multifaceted, multidisciplinary plan for your pain, in the 15 minutes or 10 minutes they're allowed to talk to a patient in, the assembly line of primary care. That's the venue in which the people should be having these follow-up conversations about how we're going to manage your pain in the medium term and how we're going to get you off of opiates and onto an alternative strategy for coping.
But as we've seen with previous articles similar to this, the emergency physician is the one who's blamed for the downstream opioid use.
We're the only ones
because we are the gateway,
who can make
right?
a difference. Once we've started them on the track to opiates, there's no getting them off.
You can't.
You can't. It's you're not allowed to.
It's that doctor who prescribed the first 6 oxycodone are the ones who are at fault for everything that happens in the next 5 years. Next article, upper respiratory infections and respiratory adverse events in pediatric ED sedation. So this is actually a really interesting article. I I haven't treated children in a number of years, but I was not aware, or if I was aware at some point, I did not remember that URIs are thought to be a risk factor for pediatric sedations, leading to higher risk of complications during anesthesia. When someone has had a recent URI, when a child has had a recent URI, the recommendation is to delay the procedure or refer the patient to anesthesia to have a more complex procedural sedation plan prior to doing whatever procedure you want. Now, this is always not possible in the emergency department. These always happen at 3 a.m. Anesthesia is not available. And so these also want to see what the true risk of a recent history of a URI was in pediatric patients. So this was a secondary analysis of a large prospective observational data set conducted in 6 pediatric emergency departments across North America from 2010 to 2015. They looked at children aged 0 to 17 who were undergoing procedural sedation by emergency physicians for a painful procedure. They looked at the rate of patients who had URI presence, which was defined as a cough or rhinorrhea, determined by family or clinician reporting at the time of sedation. And then they basically tracked the rate of respiratory adverse events, which they defined as desaturation, partial airway obstruction, etc., serious respiratory events, which they defined as apnea, laryngospasm, aspiration, or death, and then serious interventions requiring bag valve ventilation or intubation. So overall, the rate of URI in the cohort was 7.1%, and the rate of adverse events was fairly low, 6.6% of overall adverse events. The rate of serious events was very rare, less than 1%, 0.9, and the rate of interventions requiring ventilation was 1.4%. There was no difference between patients who did or didn't have URI symptoms during the procedure. The risks essentially seemed to be the same between the two groups. And then they looked also at the ketamine group to see if ketamine itself, because of the increased risk of secretory side effects, they wanted to look if ketamine had any increased risk in the kids with URIs. And again, there was no increased risk. So all in all, obviously there's some limitations here, this being a secondary analysis of a prospective study. I do think this is fairly robust data. I do think you can use this to guide your practice and you can feel more confident as long as the children don't have any other risk factors making them higher risk for procedural sedation. A URI in and of itself probably shouldn't disinhibit you from doing the procedure.
Yeah, I mean, so as you said, this is a secondary reanalysis of previously collected data, and actually, their original publication is back in 2017, going through exactly these same 6,000 children. And current respiratory illness was actually one of the things that they looked at that time and reported in that previous paper from 2017 as a risk factor for significant intervention. And in their original analysis, it wasn't either. With a really tiny increase, 1.22 odds ratio, but with a 95% confidence interval, it went from 0.5 to 3. So it's basically a no difference. And then obviously, if you go and slice that into smaller bits and look at whether ketamine or ketamine plus midazolam or propofol had any other influence on it, you're going to get even smaller and smaller and smaller bits. In any event, if you want to look at the more comprehensive version of this article, the article I'm talking about is in JAMA Pediatrics from 2017. It's called Risk Factors for Adverse Events in Emergency Department Procedural Sedation for Children. It's the same authors, and you can get the bigger picture as opposed to just this URI and adverse events of ED sedation in children. It's nice that they've done this like sub-analysis to reassure us, because I'm sure there are some people who latched onto some of these just to reinforce the fact that it is safe in children with a mild upper respiratory illness regardless.
Yeah, I think this is a good take-home message. Very often we say, I can't really take much from the study. This is one of the few ones where you can say, hey, listen, a URI in and of itself probably shouldn't concern you enough to limit your sedation practices.
Not that you would know anymore from
No.
from having last seen a child 20 years ago.
Yeah, it's been a long time since I've seen it. The thought of it terrifies me. Well, that wraps us up for another month. As always, any questions, comments, or concerns, we can be reached at annalsaudio@acep.org. Otherwise, until next time, this was Rory Spiegel and Ryan Radecki, and this was the Annals of Emergency Medicine podcast.